Hello, my name is Kimini Contreras. I'm a student physical therapist assistant at CBD College, and this is my clinical experience case study project on multiple sclerosis. So, my patient was a 35-year-old male. His diagnosis was relapsing remitting multiple sclerosis, and he was diagnosed with this in 2012. His occupation is a full-time student at CSUN. His hobbies are walking his dog, working out, and yoga. Additional information include that in 2012, this person got into a car accident and was hospitalized for 12 days due to the sustained injuries and the findings of traumatic pneumothorax. After this incident, symptoms of MS progressed. Something to note about this patient is that due to their RRMS, they are unable to perform certain positions that require balance during yoga. Another thing that he shared was that when he walked his dog, he's required to take a 30-minute rest break because his legs give up and he starts feeling fatigued. Incidents. Typical population that MS targets is women more than men, 3-in-1 ratio, between the ages of 20 and 50 years of age. In the United States, about 1 million people live with MS, 10,000 new cases per year. Clusters of people with MS are found in temperate zones of the United States, like Scandinavian countries, Northern Europe, Southern Canada, New Zealand, and Southern Australia. Here is a map from the Goodman and Fuller's pathology textbook. And this image is a representation of the world map in relation to the incidences of people with multiple sclerosis. Etiology. There are 4 types of multiple sclerosis. There's clinically isolated syndrome, relapsing remitting multiple sclerosis, also known as RRMS, secondary progressive multiple sclerosis, primary progressive multiple sclerosis. And multiple sclerosis is a disease in the central nervous system, CNS, of demyelination, inflammation, and neurodegenerative changes in the central nervous system that leads to loss in function and disabilities. So, if you want to talk about each one, the first one, clinically isolated syndrome, it's the first symptom that gives the patient or the individual an idea or an experience of what MS is. Typically, the first episode of neurological symptoms, but this alone is not enough to prove that there is multiple sclerosis, unless there's evidence of a severe lesion that occurred in the brain. RRMS is the most common one, and this type of MS I will be focusing on, given that this was the type of MS the individual I was working with at the clinic was diagnosed with. RRMS is when individuals experience attacks or relapses of neurological symptoms. And the relapses look different for every individual because everybody has a different way of their autoimmune disease that affects them. Secondary progressive MS, this is when the individual experiences occasional relapses of neurological symptoms, but rather they experience steadily worsening of the neurological symptoms. So they begin getting less relapses. The primary progressive MS, this is the least common of them all. And it is when the individual does not experience relapses at all, but rather they have a consistent decline of their neurological function. And this one is the least common. Here are some risk factors. There is no evidence proving the cause of multiple sclerosis. Some theories suggest it's due to infection, environmental factors, stress, genetics, obesity, smoking, biological, gender, vitamin D deficiency. And infections that have been studied that have a correlation to the development of MS is the Epstein-Barr virus. And this definitely has been linked to a higher risk of developing MS by 32 times. And so far, it's the strongest link studied so far. The distance a person lives from the equator seems to correlate with a risk of developing MS. And although this disease is not heritable, It has been proved that 1 in 8 individuals who develop this disease have a family member who also had it. Pathophysiology. Relapses usually happen when there's a new inflammation in the central nervous system. This patient experienced attacks about once a year and would last for about a few weeks. Relapses often made him experience double vision, and he stated feeling like he was drunk, numbness in his hands, arms, and quads. And he constantly feels numbness in the tip of his fingers, but it's not as intense as when he has a relapse. Over time, when the disease becomes more progressive, there's less new inflammation in the central nervous system and a steady increase in neurological symptoms. So the central nervous system affects the brain, the spinal cord, and the optic nerves. Here we have a picture of the central nervous system. We have a picture of a healthy myelin sheath and one that has multiple sclerosis. The myelin sheath damage interrupts messages or signals that nerves send throughout the body to perform functions like vision, sensation, and movements. Here are a few clinical manifestations: imbalance, fatigue, double vision, muscle weakness, heat sensitivity, lack of coordination, numbness or tingling, difficulty thinking clearly, frequent urgent or need to pee. And some of the tests and measures that were performed during this patient's evaluation included the Romberg test, which he was negative, the semitendon Romberg when the left foot was in front of the right, that was positive. The semitendon Romberg right foot in front, that was positive. The sharpened tendon Romberg when the left foot was in front, that was positive. The sharpened tendon Romberg test when the right foot was in front, and that was positive. The timed up and go test took, he averaged 16 seconds. These tests served as a measurable outcome that indicated high fall risk and balance impediments. The prognosis given by the physical therapist was multiple sclerosis, unspecified abnormalities of gait and mobility, and unsteadiness on his feet. Interventions for his specific RRMS included sit to stand 10 times, 3 sets of 10, functional squats, 3 sets of 10, bridges, hip abductions, isometrics, 10 seconds, 10 times, climbs with a level 4 resistance, sitting marches, standing hamstring curls with no weight, single leg balance, 30 seconds each leg, 3 times, tandem stance, also 30 seconds, 3 times on each leg, step ups with a level 2 inclination, and a 5-minute bicycle exercise. All of these exercises focus on strengthening the lower extremities and balance. No STMs, no modalities, just therapeutic exercises were assigned to him. This case study project gave me the opportunity to learn about how a neurological disorder affects biomechanics, mobility, gait, coordination, and balance of an individual. I was able to use my clinical skills and critical thinking in order to understand when it was appropriate to progress, regress, or take breaks in between the exercises. I was also able to understand what exercises triggered lower extremity muscle fatigue and why. Working alongside this patient also gave me the opportunity to engage in standby assistance when working on balance training. I was able to work with this patient about 5 times, and within that time, I was able to observe the performance progress in therapeutic exercises such as the tandem balance stance or a single leg balance. Overall, I really enjoyed working with this patient and all physical therapy. Thank you so much for listening to my presentation.